Hi, everyone. My name is Ed Bottomley from the Michigan Medicine Department of Communication, and I'm going to be your host for today's live stream on COVID-19 testing. I'm joined by our expert, Dr. Duane Newton, who is director of the Clinical Microbiology Laboratory here at Michigan Medicine, meaning he's in charge of all the testing of patient samples for infectious organisms like bacteria, fungi, and viruses, including the new coronavirus that causes COVID-19. He's also Associate Director of the Division of Clinical Pathology at Michigan Medicine and Associate Professor of Epidemiology at the School of Public Health. If you're wondering about our new setup here, well, out of respect for social distancing, we'll be doing this live stream remotely. So pardon any technical interruptions. If I freeze for a second, or if Dr. Newton freezes for a second, bear with us. We'll reload our screens and we'll move onwards. So first, a few housekeeping items about today's chat. You can submit your questions at any time, even now, for Dr. Newton to answer during our Q&A portion of today's chat. Questions can be submitted in a number of ways. You can comment on this video, but please note that your name or your profile name will be visible to others participating. If you prefer a more anonymous option, you can send us a private message via Facebook. You can email us at ask-mishmed@med.umich.edu, and we're monitoring that email address. One more time, ask-mishmed@med.umich.edu. Now, if you can't stay for the whole chat, or you want to share a recording of this with a friend, a video of this chat in its entirety will be available on our Michigan Medicine social media channels. You'll see it on our Facebook page, you'll see it on our UMich Medicine Twitter account, you'll see it on the University of Michigan Facebook page, and you'll also see it on our Michigan Medicine YouTube channel. So it should be quite hard to miss. So let's move on to our questions with our expert, Dr. Newton. First up, first question for you, Dr. Newton. What test is used to diagnose COVID? How does it work in simple terms?
Hi, Ed. Thanks for having me today. The testing that we use actually is targeting very specific genetic information in this new virus. So we are able to collect patient samples. It typically is a swab that's inserted into the nose and goes all the way back to the nasopharynx, which is a space deep behind the nose, collects cells that might be infected with a virus, and the sample is sent to our lab for testing. And we use a test that targets the genetic information in that particular virus and allows us to determine whether or not it's present in that sample. We have a couple of those assays or tests that we use in our lab. One that platform allows us to do a lot of samples at one time. It takes a little bit longer, about 24 hours to get the results for testing. We have another test that we use that we can get results within a few hours. It works a little bit different. We can't do as many, but we are able to perform that testing very, very quickly. And so depending on the patient population that we're testing, we have a couple of different options for that test.
Fantastic. Thank you for that answer. Now that this flows on, this is something you touched on a little bit already. What happens during a test for COVID? That's our next question.
So when the sample comes to the laboratory, we have to use a couple of different processes to actually access and detect that genetic information for the virus. So first we have to use a process that breaks the virus infected cells open and releases that genetic information, and then detect it in a very specific way. We actually use a process that amplifies, increases the number of copies of the virus DNA or genetic information in the sample, so that we are much more easily able to detect it and see it. And because of the number of samples we're doing at a time, that process can take several hours to just a couple of hours, depending on the instrumentation that we're using. We have laboratorians and my staff that are actually performing. They're the ones processing it and performing it, putting it on the instruments and reporting out the results.
Thank you for that. The next question, a little bit of a follow on again. Right now, who is being prioritized for testing?
There are a number of different groups of patients that we're focusing on. First and foremost are patients that are sick, that have significant infections that require them to be admitted into the hospital. And so those are the highest priority patients that we're seeing. And many of those are coming into the emergency room and then are admitted to the hospital. And so most of our immediate testing needs and the rapid turnaround time is to give results for those patients that we're seeing coming in that setting. We also do testing for healthcare workers that are symptomatic, that have developed symptoms. Typically, that's not because of their exposure to anything in the hospital. It's just living their lives outside of the hospital, and they're else. But we want to make sure that they're not sick and bringing the virus into the hospital. And so we also prioritize testing for those individuals. There are a number of different long-term care facilities that have elderly populations, people that are at increased risk for very severe infections. We do a lot of testing to support management of those patients as well. We also have patients that were positive in our hospital that have to be discharged to the facility. So we're doing testing to ensure that it's safe to transfer those patients to those long-term care facilities so that they can rehabilitate and get better and hopefully get discharged home. So those are some major focus areas but there's a lot more testing that's going on, a bunch of different patient populations as well, and a lot more expansion of testing coming up.
Thank you for that. You touched on this just a tad. Let's talk about essential employees. If you are an essential employee, do you need to be tested?
Well, that's a real question. Certainly, if you're an essential employee and you develop symptoms, you should be tested. That's a really important way to make sure that the virus isn't being spread in the community or in your place of work. The governor recently, within the last couple of days, put out an executive order that talks about testing of asymptomatic essential employees, and that's a much more challenging endeavor to undertake. We've just begun over the last few weeks testing more asymptomatic patients, people that aren't showing signs of infection, trying to demonstrate that they aren't infected. But using the tests in that way can be a little more challenging. So we're trying to understand how that process will work within our institution, the testing of the asymptomatic essential workers, because there's a much larger number of those people in the community, and that would utilize a lot of resources, a lot of supply resources, those collection kits, as well as testing resources when we start expanding to test that population.
Thank you for that. Next question up. Is the test specific to COVID-19 virus and not just general coronaviruses?
Yes, it's very specific. We went through extensive validations at the beginning of this outbreak for the tests that we brought into our lab. We had to do it very, very quickly. And it was a lot of work and very intense, but that was a very specific part of our validation, was to show that the positive result that we were obtaining was specific and directed right for this virus and not for any other virus. And that's an essential component of all the validations that we do for any new test that we bring up in our lab.
Thank you for that. And the next question we have up, this is an interesting one. Why does it seem so hard to increase the amount of testing in the US?
That's a really, really good question, and it's a difficult question to completely understand. I think it would be helpful to know a little bit about what it takes to bring a test up, and the landscape pre-COVID-19 that we were operating in, and compare that to the landscape we're in now. And normally, most of the tests that we use in our lab are developed by commercial manufacturers, and they spend a lot of time and energy performing clinical trials to show that those tests work well as they're designed to diagnose the infections that they're trying to. Those clinical trials often take several months to a year and utilize thousands and thousands of specimens being tested at a variety of sites that are participating in these trials. The FDA then reviews that data and approves that test eventually for use, for marketing and for sale, and for use by clinical labs. When this outbreak happened, there were no commercially available tests for this virus. And there wasn't time to go through that whole process of getting FDA approval. And so what had to happen, what did happen, and what normally happens in an outbreak situation is that public health labs like the CDC develop the test, and they're generally the first line for these new emerging viruses and developing new diagnostics to detect them. But they're not set up to do that for the entire country. They're not set up to do all the testing at CDC for every patient in the United States that is potentially infected by one of these, by a new emerging virus. And so there was a ramp up time that was required for us to roll that testing out, to develop them in our own labs and make it more available. There were some regulatory issues as well, because the FDA still has an important interest in ensuring the quality and the safety of any testing that's performed, even laboratory developed tests, which we use all the time in our labs. But this emergency use situation, there was a lot more scrutiny on laboratory developed tests, and it took a while for everyone to come together at the national level to say, yes, a clinical lab like University of Michigan can establish this test as well. And there were parameters that we had to follow, guidelines that we did, but we quickly were able, within a couple of weeks of receiving that guidance and authorization, we were able to bring up a test. And that was really record time for us for any new test. And over the course of about 3 weeks, we brought up 3 different tests to be able to do testing for this virus in our lab.
Thank you for that answer. Next question: are there a lot of false positives or negatives with the COVID test, and what percentage are false results?
That's an important question that we also try very hard to assess before we put a test out for clinical use. And we talked about the false positive issue before when you asked about, is this test specific just for COVID, the virus that causes COVID-19? And the answer is yes. And so that performance characteristic is called specificity. When I get a positive, is it exactly for what I'm looking for? The other question, sensitivity, is how much virus is necessary to be able to be detected. How low of a level do you need? And that is at an analytical level. We performed a number of tests to look at that analytical limit of detection and found it to be very, very low. In fact, the tests that we use now are even more sensitive than the original tests that we started out with. But those analytical performance characteristics are completely different than clinical performance characteristics. So sensitivity in a clinical sense is, how good is my test at diagnosing disease? And that's different from analytical sensitivity and how good is my test at detecting this low amount of virus. And we have a lot of data on the analytical aspects. We have not a lot of data on the clinical aspects because this is a new disease, and we don't have a standard to compare to say, yes, this person is definitively has a disease. How good is my test at detecting disease in that patient? That's how you determine or clinical sensitivity. We don't have that kind of data. We're developing it And similarly, false negatives. If we have a negative result, how likely is it that my patient is not infected? So high specificity from that standpoint means very, very good at ruling out infection. But what we have seen is that there are situations where an initial test will be negative, but a follow-up test will be positive. And most often that happens when the initial test for that patient happens very early in their disease, before there's a lot of virus present. And so that initial test might be negative, but they were truly infected and developed worse symptoms. And the subsequent test, because the clinician had a high degree of suspicion, tested the patient again, that subsequent test was positive. We've looked at that data in our lab, and it happens very infrequently. For one test, the slower turnaround time, high throughput test, it's essentially 0% of the time do we have false negatives. For the very fast test that we use for a lot of our initial testing, that happens maybe 4%, 3 to 4% of the time. There's some of the characteristics of that test allow it to be fast, but you lose a little bit of that sensitivity. But still, it's a very, very infrequent situation that happens.
Yeah, and Dr. Newton, you pretty much answered my next question. Are we having to retest patients several times after a negative test?
We don't have to, because the performance is what it needs to be. I think as we get more experience, we can generate more data to support that. One of the challenges, though, is that there are some recommendations that have been put out by public health agencies that say that you have to have 2 negative results for patients to discharge them from your institution and release them to a new setting, whether it's a long-term care facility or to release them home. And it's not clear whether or not that's really required and how that testing should be used in that situation. There are other discharge criteria that are based on the patient's symptoms that don't use testing in the decision making, that you can also take into consideration. So that's a really difficult process right now to understand, but for diagnostic purposes, it's very infrequent that you would need to do repeat testing to confirm or to rule out a diagnosis.
Thank you for that. We are 20 minutes in now to our live stream almost, and you've been answering a very broad selection of questions. We've got quite a few more to come. The next one that we have up for you, do you think there will be a time where anyone can get a test, even if they are asymptomatic?
I think that that time would come when we have more resources available to us. Right now, the biggest limitation is from a testing standpoint are the supplies, the collection supplies to collect the samples to submit for testing. Most labs have enough testing supplies to actually perform the COVID testing, but it's the sample collection. Now, that's a generalization. That's certainly our experience in our lab, but other labs have different challenges, and some institutions are even having difficulty getting any tests to be able to perform. And so they have to send out their tests to reference labs or public health labs, and that delays. So in the current situation where we have a lot of people with disease, that it's very difficult to perform testing, to get all that testing performed. A situation where testing asymptomatic people outside of that puts a further strain on the resources, and we have to be very, very careful how we do that and how we apply that. We have some situations where we're testing asymptomatic individuals depending on the situation. For example, there are some emergent surgeries or important surgeries that we need to perform on patients because we can't put that off at all. And so we want to make sure and they're not symptomatic, but we want to make sure that they're not infected and not showing symptoms. So we might test that patient to show that they're not infected, so that we don't have to use the kind of precautions that you would for a COVID patient in that setting. So there are situations where we're doing that, but it's not broad, and it's certainly not everyone in the state or everyone in the country. We don't have those resources.
Okay, and my next question for you, Dr. Newton, what makes a swab test disease specific? Can you use the swab you use for flu, for COVID-19?
We do, and we have. And it was really, really hard when we started out, because we had a lot of flu activity going on at the same time that COVID was emerging in Michigan. And so my lab was performing a lot of testing for flu and a lot of testing for COVID. And the symptoms that those patients exhibit overlap significantly. And so for many patients, almost all those patients, we were doing the testing for both from the same sample. And so fortunately, we didn't need to collect separate samples for that testing, but we did have to do both tests. And that was a very big drain on those resources initially, because there was still a lot of influenza activity and a lot of testing that was necessary for there. So the collection kits are not specific for the virus. They're for any respiratory virus. You can use the same mechanism for collecting the specimen, but the actual diagnostic test that we use in our laboratory is very, very specific. It might be the same platform. It might be using a similar approach, the same kind of equipment, the same technologists in my lab are performing them. They're trained in that test how to do it. But the test is unique for the virus that causes COVID.
Thank you. We're going to move on to a few questions on this topic. The first of which is, what is an antibody test?
So antibodies are substances that are proteins that are in our blood that are made by our immune system in response to an infection. And in most cases, but not all, that antibody helps protect us from getting reinfected by the same infectious organism, in this case, potentially a virus. So the generation of antibodies by your immune system is intended to be a protective mechanism to help prevent reinfection from something that you've seen already.
Next question on antibody tests for you, Dr. Newton. Will an antibody test be able to tell me if I had COVID in the past?
In most cases, it should. And that's a really good question that we and many, many others around the country are trying to answer. There are new tests that have been developed to detect COVID specific antibodies. What it can tell you is that if it's positive, that you have been infected. But what we don't know is how long, in the case of this infection, how long those antibodies will persist and will be detectable in your blood. For many, many infections, the antibodies that are produced are present for your entire life, and you can detect them. And sometimes they're there, but they're at low levels that you can't detect. And sometimes they go away and only come back upon reinfection, and it's part of your immune system memory response to regenerate those. So what we don't know is really, because we haven't applied this test in large populations yet, we don't know how many people that were truly infected actually generate antibodies, and once those are generated, how long they will last.
Does Michigan Medicine have an antibody test?
We are evaluating several antibody tests. So I think there are about 5 different commercially available tests that we've brought in, that our chemistry lab, that's led by another clinical pathologist, a colleague of mine, Don Gicario, his lab is evaluating those assays as we speak and are beginning to collect. They've tested samples that we've had archived in our lab, and they're beginning the process of collecting specimens, blood samples from patients that we want to test going forward prospectively.
Another antibody question that we have for you: can recovered essential employees receive antibody tests? Do they need to prove a past positive test? If so,
So that's actually exactly one of the approaches that we're taking in our lab, is to test employees that we knew that were positive to see did they develop antibodies. How that information is going to be used and whether or not any proof of immunity is going to be necessary, that remains to be seen. And we don't really understand the dynamics, as I said. We don't understand how long those antibodies will persist and how likely we are to find it in a truly infected person. So we're starting the process looking at healthcare workers that were known to be positive and collecting blood samples from them and evaluating it even more broadly moving forward.
fantastic. The next question: a lot of people, from politicians to scientists, are saying that we may be able to ease stay-at-home restrictions with more testing. What is the thinking behind that?
The thinking, from my perspective, I haven't been consulting directly with the governor or with the president, so I can't tell you specifically what the thought process is. But I feel like the thought process is, if we are able to test a broad enough range of people in the population, we would know how prevalent the infection was in the population, how many people have been exposed already. And if those rates are high and everyone has recovered, presumably the individuals are protected from reinfection. And so you have generated a huge amount of population now that are not susceptible to infection, and would generally reduce the likelihood of transmission. But then if a person is infected, that would be a rarer situation, and you could identify that person. You could isolate that person and do contact tracing around that person and monitor the exposed individuals to see if they become infected, and really target testing to isolate those cases that pop up subsequently. So I think that idea is then putting a blanket of testing around in the general population to understand really how many people are infected right now or were infected, either using our test or a serology test, and that giving a better idea of how much disease is in the population. But again, as I mentioned with our test, the limitation, there's significant limitations in the supplies. And so we certainly don't in our state have enough supplies to test everybody in the state with our DNA test, or our RNA test, our molecular genetic test. It remains to be seen whether or not there's going to be enough capacity to use an antibody test in the same way.
Thank you. I think that's a big question. Thank you for answering that. Your next question up: do you have an opinion on when it would be safe to reopen the state?
I don't. And it's a really hard and difficult thing to say, because I have a desire, just like everyone else, but I don't. I think the important thing that we've seen is that there seems to be a leveling off, and everyone talks about flattening of the curve, and it seems like the amount of disease in the state is leveling off. And I feel like that is certainly because of the efforts that we've taken in social distancing. And I think the question that I feel comfortable asking or answering is, do you feel like all of this was necessary? Do you feel like we needed to go to this extent? And my close colleague here in the lab answered it very eloquently. He said, I know that we'll never be able to answer the question of did we do too much, but we'd quickly be able to answer the question, did we not do enough? And so I feel like the things that we've done have had an impact, and we continue to do that. And I feel like we still have a little more time that we need to really see whether this leveling off is actually a decrease in disease or just a normal state that we're just going to be living with for a while. And I think those are two different situations, and we would respond to them differently.
Yeah, thank you. Thank you for that answer too. These are a couple of tricky questions for you there. What do you think about the idea of immunity cards or some other indication that a person has been tested, has antibodies, and therefore can move about freely?
It concerns me at a personal level, but also at a professional level. I don't think that any of our tests are good enough to prove anything, and no test is good enough to prove anything. I think we have we're developing a lot more experiences with tests. We know how they perform, but we also know what their limitations are, and no test is perfect. And so we certainly know that with our test for the virus, the specific test that we're performing. We're starting to develop a greater bank of data that helps us understand how these antibody tests are performing. And it's way too early to project how that's going to be used, and how, even if it's going to be useful, it'll be useful in telling us broadly from a population perspective how many people were infected. But on an individual patient level in this situation, just to prove something for that person, I'm not sure that if and when that will ever be the case.
Thank you. Thank you for answering these questions, Dr. Newton. It really strikes me that things are developing, things are being learnt. So you jumping on here to answer these questions is really, really helpful. The next one that we have, are all antibody tests the same?
Well, the answer is no. And there's a lot of reasons why they're different. There are different types of antibodies, and there are tests to detect those types or classes. Our immune system makes different types of antibodies that have different roles, and you can do tests to detect those different types. And those different types may or may not tell you something different about the infection in that person. So that's one difference.
Sure.
Another difference is that there are just an inordinate amount of assays that have come onto the market, and we know very little information about the performance characteristics of these assays. I'd say there are hundreds of them. There are different manufacturers. There are different ways that they're being produced. There are different ways that they are operated in the lab that make it easier or harder or more complex for a lab to bring in. There are different speeds at which you can get results. There are some assays that require actually drawing blood and sending that blood to a lab. There are other tests where you could do a finger prick and use a drop of blood and put it on a card and get a very rapid result in 10 or 15 minutes. We know nothing about how those really perform and how accurate they are, or how clinically relevant the information is that they provide. So there's very little information out there, and that's what makes it very difficult to answer these questions. And it's one of the challenges, is because I think theoretically and conceptually, this is how a test should work. But the reality is it takes a while to get that information to prove that it does work in that way. And we're all struggling with getting those answers quickly. And they don't, from a science standpoint and from a medicine standpoint, this is a situation where it's taking time.
And I really appreciate your measured answers on some of these things where, things are developing as we speak almost. The next question we have for you, Are construction workers who are now able to be tested, should we be encouraging people working in grocery stores and other essential services to get tested?
So that's a really good question. I can't speak to construction workers specifically. I'm not sure all the different classes of employees that fall under that the description of essential employees. But as I mentioned earlier in the broadcast, the governor came out with new guidelines this week about putting a priority for critical infrastructure workers, including asymptomatic workers, that allows for them to be tested in addition to these other critical categories that I talked about before. This guidance from the governor, or this executive order from the governor, did put some qualifications in, as I understand it, specifically as your capacity allows. And so our capacity right now is focused towards the very ill patients and the healthcare workers that are taking care of these patients, and is not able to broaden very, very quickly to include asymptomatic individuals like this. So how, again, it feels like we're building the bridge as we're walking on the bridge. And, we come to these cliffs or the edge of that bridge very, very quickly. And then we build some more, but then we get to that bridge again. And it's really difficult to know exactly. I think it's going to be important to make sure whatever we do, that we do it safely, because we don't want to open up floodgates, allow everyone to go back to normal activities, and we have a lot more disease start up again. And that would be a huge challenge to deal with.
Thank you. And you touched on this one. I think it's worth mentioning this again in this question. Now that healthcare workers without symptoms can get tested, how often will they have to be tested to make sure they haven't gotten infected? And should they refrain from getting tested because they want to make sure there are enough tests for people with symptoms?
That's a really great question. And I think I've actually known several people who are otherwise healthy, don't have any underlying disease, that really felt like they were infected with this virus and chose not to go in to get tested because they were sick, but they didn't feel like they were getting worse, and they didn't want to burden the healthcare system in a way that would add additional, use up additional resources that might otherwise be applied. So I think that's a really a great thing to consider. Could you repeat the first part of the question, Ed? I'm
So,
sorry.
oh, no problem at all. So now that healthcare workers without symptoms can
Oh,
get tested, how often will they have
repeat.
to be tested?
Yeah, I understand now why I forgot that, because I don't have an answer to that question. So nobody knows that, and I think we don't know how long the virus lingers before you're negative, and we don't know how much time to give between, what kind of interval between the diagnosis and enough, there being enough time for recovery to happen to ensure that. You shouldn't have to have multiple repeat negatives, but those, as I mentioned before, there are some criteria about discharging patients that include repeat testing within a 24-hour period for discharging purposes, making decisions about discharging. Again, that's a very difficult situation to go with, but from a diagnostic standpoint, for because of the performance characteristics that we use and we know about our test in our institution, if we had a negative result, physicians responded accordingly, and they
Sure.
they might have kept patients in precautions because they were symptomatic, but they were maybe not necessarily considering COVID. And there were a few situations, as I said, where the patients got worse, they retested, and they were positive again. But we had very, very few of those. And so a negative test was very, very good at ruling out infection.
Thank you. Thank you for that. Next question up for you. Can rapid antibody titer tests be truly relied upon for accuracy?
Yeah, we don't know. And I think those are the points that I was trying to make with my discussion on antibody testing before, that there we have very little experience with them. Many large labs are doing those studies and trying to figure that out. I think all of our testing, the more quickly we're able to provide results, the more immediate the impact can be on the patient. And we use that approach routinely for all the testing that we do. How quickly can we get these results out and have a meaningful impact? That's what we would like this to be able to do, but we're not sure where that is, and hopefully we'll get some data to answer that question.
Great. The next question up for you. What is the role of commercial testing companies?
A huge role in helping to take on some of that testing burden that can't be managed by a routine clinical lab. And so often in a commercial laboratory, they have the ability to do very, very high volumes of testing, lots and lots of specimens per day because of the platforms that they have. They may have the same kind of platform that we have in our lab. They just have 10 times the number of them because the space that they have available is much larger. They have more people to do that. Again, the resources could be a limiting factor, but often they have the ability to provide testing for larger numbers of patients. And so in these situations where we're talking about expanding testing and doing more testing for asymptomatic patients, a lot of that capacity could be and is being used or being filled by commercial laboratories.
Fantastic. The next question we have up from our social feeds: are there any home-based testing options?
I'm not aware of any. What seems to be more popular is potentially home-based specimen collection, or more simple specimen collections that don't require using a swab and inserting it into your nasopharynx. We were looking at the utility of nasal swabs or throat swabs, or even saliva. There are some studies that have looked at saliva as an acceptable specimen type. But all those kinds of options need to be evaluated. In other clinical situations, we use self-collected patient specimens, and they've worked adequately, and maybe sometimes even better than a physician-collected specimen. So that might be something that's an option, but not really anything for performing tests at home. And I would be very, very leery of purchasing any that you might see. That would be a buyer beware situation. Those are not regulated, have not been approved or evaluated, and would strongly recommend not pursuing that on an individual basis.
Thank you. I think that's a really important point. Next question up. There have been reports of people testing positive, recovering, and testing negative, and then testing positive again. What do you think is going on there?
Yeah, that's a hard question to answer because I don't know anything. I've heard similar reports, and you don't know anything about that patient. So was it a patient where maybe they have some underlying disease, and maybe they were in the hospital and their disease burden diminished and the amount of virus diminished, but something else happened with them, and maybe their immune system stopped working as well as it should have because of everything that was going on, and it caused the virus to start to come back. That's theoretically feasible. That never went away, but it just was at a low enough level that our tests didn't detect it. That's feasible. Not, I have not seen any reports of that in our institution. Another situation, which is also feasible, is that the person was positive, was normal and healthy and recovered, was out in the community and got reinfected again. And so that would be concerning, because that means that that prior infection didn't protect you from getting reinfected. Again, we don't know what was going on with this person or in these cases. I think the other issue could just be a specimen quality issue, in that middle test, they didn't collect a good specimen. And so if we don't get a good specimen and don't get enough patient material, then it could be falsely negative in that situation as well. So there are a variety of challenges. I think the tests detect virus genetic material at the early stages of disease. That's very much coordinated or correlated with infection in that patient. As the patient starts to recover and the virus is being killed, maybe some of that genetic information lingers, but it doesn't represent actual infectious virus. And so repeat testing in a long period, after a long period post recovery, may not be picking up really infectious virus. It may just be picking up that genetic material that's lingering around. We've seen that happen in other with other types of infections as well. So there's a lot of reasons where you could have these situations coming up, and it's very nuanced, and it's very, very difficult to interpret it. And that's why it's really important for the people that are using the tests and making decisions based on test characteristics to really understand and work with folks like myself to know what the limitations are and how to interpret this information so that the right kinds of decisions can be made.
Thank you for that. And the next question we have up: I have had multiple people claim or ask me if having the influenza vaccine can cause a false positive COVID test. I haven't found journal articles to support this, but I thought I'd ask an expert. Thoughts?
So I will say, from my professional opinion, is that there's no way that would happen. Completely different viruses, and the targets that we use for our genetic tests are very, very specific and unique. And we actually tested specifically against influenza virus and a large range of about 20 other viruses that we see routinely, and showed that there's no cross reactivity from that standpoint. I think it's really, really important to understand whether or not there's any cross reaction in the antibody tests. There's no reason to expect that an antibody for influenza virus that you would generate through a vaccine would cause a false positive in a SARS coronavirus antibody test. But those things would be evaluated, and we have lots of people that are vaccinated and would have antibodies, and so we would know pretty quickly if that would happen. So shorter answer is no way.
Okay, thank you for that. The next question we have up: when do we think that antibody testing would be up to scale in a large way? And also, would this be helpful as an indicator to know if a virus that may have presented before the pandemic was in fact COVID-19, say back in December?
So one of the things that is really an interesting question, that's kind of part of that, is trying to do some evaluations of archive samples to see can we detect evidence of this virus circulating before it seemed to be apparent? And I know that those studies, both for the testing that like we do in our lab to look for the genetic material in specimens, as well as antibody testing, those studies are being performed going back on some of the archive materials from the fall and winter. I don't have any information about that, but I think that's a really, really important thing to see. Could you put the question back up on the doc?
Oh, of course.
Thanks. The one after that.
Let's see.
Oh, sorry. Yeah, it might be good just not to clear them so quickly.
Yeah.
I kind of have the attention span of a dog after a squirrel sometimes. And
me, you know what? Me too. Let's see if the team working on the other end can pull that question in. Let's see. The next question that we have. This is an interesting one. What characteristics of an antibody test would make it suitable to determine if a person can donate plasma for a sick person? What type of antibody is important for a good donor? Now, I know we have the Red Cross has information on its website. We want anyone who has a confirmed case of COVID-19 to consider giving plasma to the Red Cross.
Yeah, I can't answer that question. That's out of my area of expertise, but I know that there are ongoing clinical trials around the country, and Michigan Medicine is also participating in those where plasma from recovered patients is being used for therapeutic purposes to treat people that are infected currently. And it's not entirely clear to me what type and quality and amount of antibody needs to be present. But I think those are the things that are trying to be answered through these studies. And so that I think there are a lot of folks like the person asking this question who probably are really willing and interested to be donors and help in this situation. And I'm sure there's going to be more information coming along in the near future. And I think I remember the other part of the question that was asked, and it had to do with how long would it take to scale up testing to be able to really test more people. And again, I think it's something that's going to take several weeks to months to really have the kind of capacity that's necessary to do the very broad population-based studies that people would like to do. Those are ongoing, and a lot of it depends on the types of tests that are brought up and the types of instruments that they can go on. So those really, the quick, rapid 15-minute cards, that's not really going to be useful for testing 1 million people. And so we have to have these high throughput systems to be able to do that. And it's taking a little while for that to come.
Yeah, thank you for remembering that first off, and thank you for answering it too. The next question we have up: how many people can Michigan Medicine test in 24 hours?
Right now, it's somewhere around 1,000 patients. We have, with our combination of platforms that we use, that's our throughput. The main issue, though, is how to balance our supply of collection kits with that capacity for testing. And so that's been an ongoing challenge that we're working on every day. But it's right around 1,000. I think we could crank that up a little bit more if we needed to, and maybe do 1,500 right now with our current systems. We have some additional equipment that we're expecting to receive within the next few weeks that would enhance those numbers even further.
Fantastic. I think we have about 4 minutes left and about 4 questions left. So let's see how many of these we can get answered. The next one for you: are you doing any testing of past samples to see if this virus was in Michigan in 2019 or early 2020?
Yeah, we are not, but I know that those are going on, and that's a really important question from a public health standpoint, and the CDC is interested in that, and colleagues of ours in the School of Public Health are actively investigating that question and working to answer that.
Perfect. And this one, a little bit of a follow on: are you able to use the test results cells for research purposes other than to determine positive or negative results for COVID-19?
So there, yeah, that's a really good question, and we are developing processes to. We certainly save all of our samples. The university is very, very interested in this and has created a task force that is designed specifically to address research questions related to these archive samples. And so there are a number of samples that we've collected. There are a number of samples that are blood samples that have been collected for other diagnostic purposes. There are even samples from patients that unfortunately passed away and had autopsies performed. And that those can serve a very, very important clinical and academic purpose to really understand the dynamics of disease and what caused those patients to die. And it's another way, in death that that patient can give to others. And by having that autopsy, we can learn more about what's going on. And so, yes, we have a lot of activity around that, and we're starting to have people put together proposals to do some of those kinds of studies.
Thank you. Thank you for that answer. Next question: why are we using nasal swab testing for patients with GI symptoms rather than stool testing?
That's a good question, and there are some respiratory viruses that cause symptoms in the upper respiratory tract, but also cause GI symptoms. And when in the course of the disease that you start to see those varies, and the utility of one specimen for versus the other can vary as well. I know that we know that some people with COVID infection have GI symptoms, but not everyone. We do know that everyone with COVID infection has a respiratory tract infection, and we know that that virus replicates very easily in the respiratory tract, and so that's why we focus on that. And I think the more we learn about the infection and the more patients we have and the different specimen types we are able to collect, we can start to parse out and define, what specimen type might be better or worse than others during the course of disease.
Thank you. Thank you so much for answering such a broad range of questions. My last one is always the same. Dr. Newton, is there anything you think we've missed?
I don't think we missed anything. I want to thank you for the opportunity to talk, and it's really it's great timing. We didn't know this, or we didn't think about it when we planned this, but we happen to be right in the middle of Medical Laboratory Professionals Week, and so it's a great honor for me as a medical laboratory professional to be able to share some of what we do to our audience and represent the millions of clinical laboratorians around the country that are working very, very hard. I feel like they're the unseen and unheard warriors in this fight against COVID. Behind the scenes, they're not touching that patient directly, but they're touching parts of that patient and have a really, really important role to play in the fight against this outbreak. But they do that every day, and they do that all day long and every day of the year for all of our patient care needs. And it's really important for people to understand that this silent army is working hard to protect us. And I'm very much appreciative to be able to share some of our story today.
We're very appreciative of you too, Dr. Newton. Thank you so much for highlighting this silent army. Thank you for joining us for this really good discussion. So many questions, as I said, so many little topics. It's great to have your expertise. For more information and resources to help navigate this difficult time, you can visit uofmhealth.org and click on the coronavirus links right on the front page. And for the CDC, you can go to www.cdc.gov and click on the coronavirus links on their front page too. Dr. Newton, thank you so much for your time and expertise today. And thank you to our viewers too. Have a good afternoon.